everyone. My name is Dr. Jill Carnahan, and I'm here to talk to you about chronic viral infections in illness and the patterns that we see, and to bring you some cutting-edge solutions to these patients that we see every day in clinical practice. So before I share my slideshow, just a little bit about me. I moved to Boulder, Colorado in 2010 to start my own functional medicine clinic. I first partnered with our beloved King Bob, Dr. Robert Roundtree, and we shared office space in the foothills where we used to walk out at night and see mountain lions. And he was so generous to help me start my practice and to get up and going. And currently I have a wide range of clinical services in Louisville, Colorado, just a few minutes away from Boulder. There are many services that we offer now. We have a massage therapist, we have chiropractic, acupuncture, naturopathic therapy, infrared sauna therapy, IV vitamin therapy, and nutritionist, holistic health coach, etc. So it's been really fun to see the growth and the need for functional medicine. And I love being near the mountains because my favorite things to do on the weekends are hiking and playing with my puppies. So let's dive into this primer that I have for you today. So I want to talk about viral infections and chronic illness, a primer for testing and treatment. So first of all, I want to talk about the problem. Many of you know viruses are a big deal in your clinical practice, but they're hard to determine. But before we can talk about viruses, I want to talk a little bit about how I frame functional medicine. So when I'm talking to patients, I really say, it's very simple. What we do in functional medicine is look at your toxic load and your infectious burden, and then all the inflammatory cytokine sequelae and immune dysfunction and neurological dysfunction and et cetera, that we see in conjunction with this toxic load and infectious burden. And it might sound oversimplified, but I really feel that at the core of most of the patients that we see, this is the real issue. So we can't really talk about viruses until we talk about the terrain. And I think it's interesting because coming out of the pandemic with the coronavirus, we talked a lot about the germ theory, or this theory of infectiousness of a virus and how is it transmitted, et cetera. But maybe more important is we talk about the terrain, because in functional medicine, we're always dealing with terrain. And if we have a healthy terrain, a healthy immune system, a low infectious and toxic load infectious burden, then we are going to be more resilient and less likely to get ill from viruses such as coronavirus. So it's easy to see that our toxic load is increasing. There's so many chemicals and things that are being put into our environment all the time. And this is overwhelming our natural defenses. So whereas before we might have had the resilience to withstand an epidemic, pandemic like this, now we are all in a much more weakened state because of the environmental toxic load. And then other infectious underlying processes cause a weakened immune system and kind of a burden, as it were, that there's other loads of infections that are creating more inflammation and actually priming the system, which I'm going to talk about today. They can also lead to viral reactivation. So many dormant viruses like varicella or Epstein-Barr stay dormant as long as we have a healthy, robust immune system. And when we get under stress, have surgery, get over the age of 65, et cetera, we are more prone to having these viruses reactivate and causing illness or symptoms in our patients. Viral and fungal infections both are opportunistic. So as we talk about the viral infections, we have to remember here that it's the terrain, the milieu of what's happening in the body that allows that to either take up residence and become an infectious issue or not. Because clearly there's many people who have been exposed to viruses or in this pandemic, the coronavirus, who haven't gotten ill. So what's the difference? And I'm postulating that terrain is really the important thing here. And we'll talk about how that connects directly to your gut microbiome. So toxic load plus infectious burden equals systemic overwhelm and inflammation. And again, that's how I talk to my patients. This is what we're doing. This is the basics of functional medicine. And they really do understand. So infectious burden, I want to just look big overview here because we have epidemic of Borrelia, Babesia, Ehrlichia, Bartonella, and Bartonella-like organisms. And if any of you are like me, where I was like, I am not going to treat Lyme disease years ago, and you cannot do functional medicine without addressing it, or at least knowing someone who does address it, because it's such a big deal. There's so many more people who have a toxic load or an infectious burden or weakened terrain, and who get these infections and they become a real issue for our patients. And then opportunistic infections like protozoa, mold, viruses, etc., which we'll talk about today. And this lecture is not on mold, but as you well know, I am passionate about finding if this is a culprit in patients' environment. And we're seeing just epidemics of mold-related illness because of poor construction, because of environmental toxicity, because of patients who don't understand that their home is becoming a toxic place for them to live. So other factors influencing the immune system, again, this looks at the whole terrain. If there's other infections like parasites, bacteria, if there's toxicants or toxins in the system, dental infections that are occult or hidden, food additives or just poor food quality in general, plastics, stress, endotoxins. So we're going to talk a lot about the gut and endotoxins today. That's going to be the focus of why I believe that that can prime our cytokine system for response abnormally to viruses, fungi, mold, and EMFs. So let's talk about viruses. This is a rendition of what the coronavirus might look like, which by now we're all so tired of seeing. So I want to talk first about other types of viruses and how they've been linked clearly to dysfunction, cytokine storm, autoimmunity, and inflammation. This particular study talks about proposing that the herpes virus families like Epstein-Barr and HCMV, HHV6 can cause and contribute to chronic fatigue syndrome and dysregulation of host immune response. This just is a diagram or a chart where we see that there's many different infections virally related that cause post-viral fatigue. Now, if you have been watching the studies that are coming out, you're going to see that with the coronavirus, we're seeing sequelae like lots and lots of neuroinflammation and neuroinflammatory sequelae and fatigue. And if you have treated any patients like I have that have COVID-19 or presumed infection, many of them are complaining of fatigue for months or weeks after the virus. So this is a very real issue. And I think as more and more people are affected, we're going to see more of the fatigue, inflammation, autoimmunity as sequelae of this pandemic. This is just another chart. I really like this because you can see all the herpes virus categories and the links to cancer and Alzheimer's disease and encephalitis and pneumonias and myocarditis and optic neuritis and many itises, so that we know that a virus, if infected, is an inflammatory trigger. And as we also know, these viruses don't just go away. So they can reactivate during times of stress. And I'll show you some studies on that as well. Stress linked to viral reactivation. So here we are. There's clear links to viral reactivation of stress and the immune system. So fatigue in medical residents leads to reactivation of herpes virus latency. So interesting, isn't it? That in residency, we all remember those trying times and lack of sleep, poor food, lots of stress, difficult attendings at times. And this showed that significant stress caused a reactivation. So there's a clear link between stress. This is also why I thought so interesting during this pandemic that some of the behavioral things that we were implementing, they cause stress, they cause isolation. And not that we didn't do appropriate measures, but certainly I did not see a lot of talk about the fact that isolation leads to stress and can be one of the most significant factors in weakening the immune system. We weren't really talking about that in this discussion. This talked about, this was actually from that study where rest, there was low levels of Epstein-Barr titers change, but with low stress and high stress, there was almost a doubling of the levels of reactivation. This is in Space Shuttle mission astronauts, and it showed that multiple latent viruses reactivated in astronauts. So not only the atmospheric stress, but just the stress of being on a Space Shuttle mission caused latent viral reactivation. Same thing here, varicella zoster, so shingles. Plasma cortisol levels and reactivation of latent Epstein-Barr in response to exam stress. So this studied poor college students under exam stress and did find that academic stress did not elevate cortisol levels, but did increase Epstein-Barr antibody titers. So interesting, because they actually didn't see the cortisol stress response, inferring that maybe the cortisol was not directly related to that activation, but they did see increase in titers. And then autoimmunity. There are so many studies. I just pulled a couple here linking viral reactivation in autoimmunity. And I'm going to show you a slide on autoimmunity and coronavirus and why I believe that there's some commonality here because of that activation of Th17 and the increase in autoimmunity. I also do believe that we're going to see sequelae after this pandemic of increase, like I said, of neuroinflammation, neuroautoimmunity, and just autoimmunity in general. So we are set up, unfortunately, to have business because these patients need functional medicine. They need the root cause analysis, and we're going to see a lot more of them coming into our clinics. Sad fact. So Epstein-Barr and MS, this talked about dose-dependent response between MS risk and antibody titers. So again, a classical autoimmune disease of neuroinflammation that is linked with, maybe not causation, but at least correlation with increased antibody production of Epstein-Barr. And this shows autoimmune syndrome secondary to infectious relationships. So once again, just proving that viruses can contribute to autoimmunity. And we see the microbe, measles, and Zika virus and strep in this case can all cause issues with autoimmune syndromes, especially neuroautoimmunity. This I just thought was interesting from 97, where exposure to 50 hertz induces activation of the Epstein-Barr virus genome. So again, we don't know all the environmental effects of electromagnetic radiation or of the toxic loads, the toxins that are in our environment, but we do know that they play a big role, and they're part of our assessment as functional medicine clinicians and looking for root cause. So let's talk a little bit about what you're probably so tired of hearing about, and that's the coronavirus. Clearly, we know that the proteins are linked to activation of ACE2 receptors, and that's how they get into the cells in this disease and this illness. So physiological impact of ACE2 receptors is to increase activation, increase in brain circulation, but the negative effect and why we see neurosequelae is neuroinflammation, oxidative stress, and neuronal apoptosis, which can actually lead to brain damage. So very, very interesting because this is going to have an effect on both the brain and the heart. And again, we will likely see more sequelae, more information as the studies will come out in the next several months and years to come. This particular study shows new research from the Journal of the American Medical Association suggesting 40% of individuals hospitalized for severe or critical COVID-19 developed ARDS, and about 50% died. So again, the cytokine response from COVID-19 can create lung inflammation and damage. And it isn't very classical, which I'll tell you about in a few minutes. The patterns that we see, they're very, very interesting. It seems that this ARDS in coronavirus is less directly due to the virus itself and more related to inflammation or cytokines in the body's response to the virus. And again, many of you have read this and know this very clearly. So mechanisms, acute respiratory distress syndrome is so things that we could do for this would be block excessive WBC and neutrophil infiltration, break up excessive mucus with things like N-acetylcysteine, supporting immunity. Impairment of cell membranes can be done by strengthening mucous membranes, supporting innate immunity, and reducing reactive oxygen species. We're going to talk a lot about that as well in this lecture. And if we can use nutrients to compete with binding, that enables the entry of the virus, dietary changes to lower DPP4 and bind ACE receptors. This can also be things that would aid in the treatment of coronavirus. So what is happening in this situation? Patients present with life-threatening hypoxia, but show typical signs of distress. Ventilators aren't really working like we think they should be. And many patients reported loss of taste and smell, which we now know is likely associated with the zinc deficiency. Now, why is that? So this reactive oxygen that happens, this oxidative stress that happens from the virus activating ACE2 receptors intracellularly causes depletion of both antioxidants like vitamin C and zinc. That is why we've seen emerging evidence that perhaps those things will be helpful in future in the treatment of the virus. Many patients have cardiac damage, and fatality rates are wildly different. So lots of other things going on. I wrote an article recently that had a lot of traction that talked about this increased intracellular oxidative stress at the core of all pathological infections. So basically, many infections that we treat cause this increased oxidative stress, increased cytokine response, and creates reactive oxygen species. So that reactive oxygen species production is the core of a process at the base of what causes this hypoxia and damage. So all of a sudden, oxygen cannot be delivered appropriately to the tissues, and we see hypoxia, even in the presence of before the lungs are damaged. Now, this ROS can also cause kidney damage, lung damage, brain damage, heart damage, etc. But the real mechanism is not just a pure respiratory failure, it's a lack of oxygen delivery to the tissues based on the reactive oxygen that's happening. So viral activation releases inflammatory chemical compounds, histamines, etc., which provokes the generation of pro-inflammatory IL-1 family members, and this creates a damage. Now, the reason I pulled this one up is because the big question in a lot of the boards I'm on and things are, does mast cell activation syndrome have a greater risk or not of getting seriously ill from coronavirus? And I think there may be some evidence that that is true. This one, again, newer article coming out just last month on coronavirus and autoimmunity, again, postulating that these same mechanisms we've seen with Epstein-Barr, herpes simplex viruses, etc., are causing an inflammatory cascade and can contribute to autoimmunity. I think we're going to see the same thing, sequelae, after this is all said and done. We're going to see this in our clinical practice, patients who've had the virus and who all of a sudden have worsening autoimmunity or new onset autoimmunity. This just, again, a study in the beginning from China showing the early stage case fatality rates associated with cardiovascular disease, diabetes, chronic respiratory disease, hypertension, cancer, etc. Very few were associated with no health condition. So how interesting is that? Because these things are also at the core, as I'll show you, of endotoxemia and responses from the cellular cytokine response. This is just showing you some of the evidence of those chronic diseases and inflammatory cytokines being at the base. So how does this relate? Here's how I see it. Basically, if someone is primed with a cytokine response because they have diabetes or high blood pressure or autoimmunity or any of these conditions we've talked about, they're going to have that primed inflammatory IL-6, TNF-alpha, IL-2, etc., primed and ready to go so that when this virus comes in, that cytokine response is already activated and creates a lot more damage with reactive oxygen to the tissues. So this shows hypertension, endothelial response to inflammation in cardiovascular disease and in diabetes, which is, well established clinically. So thoughts on the coronavirus are that it can bind to the receptors as well as established. When these receptors remain available for viruses to attach, enzyme production is low or impaired. But when the receptors are open, if systemic inflammation is not addressed, that LPS, low-grade systemic inflammation, probably drives this whole process because we see such a high correlation with the diseases that are associated with LPS endotoxemia and LPS activation and the cytokine response and actually the worsening of coronavirus in outcomes. So I'm wondering if the LPS can impair ACE2 enzyme production, leading to lung inflammation or inflammation of other tissues, and if metabolic endotoxemia and the resulting inflammation are the root contributing factors in the risk. Now, again, this is theory, and a lot of what I'm saying here in this lecture, I will just say a disclaimer. I'm not claiming to treat any certain disease, including coronavirus. I'm just talking about the theories behind the damage and the autoimmune sequelae and the things that we're seeing. And as good functional medicine doctors do, we're also good detectives. So we're looking for root cause and other things that might be contributing to our patients' illness. This is just 2 studies on ACE2 exhibiting protective effects against LPS-induced acute lung injury. So this is very closely connected to LPS endotoxemia. So lung inflammation is a common consequence, and this is exposure to PAMPs and DAMPs. So PAMPs would be like your pathogen-associated endotoxins like LPS. DAMPs would be damage-associated endotoxins. And in this illness and many viral illnesses, we have both PAMPs and DAMPs because we have pathogens like the virus, like LPS, bacterial coatings that are triggering immune response. And we also have DAMPs, the damage that's happening from that reactive oxygen on the tissue level. So just wanted to tell you that probiotics and respiratory virus infections have been around a long time because I'm going to spend the rest of the lecture talking about solutions, including spore probiotics and the promise that they have in treatment of inflammation related to LPS, endotoxemia, and cytokine storm. So this talks about 28 trials, probiotics beneficial effect. Only 5 showed no clear benefit. And these were various probiotics. This one also, probiotics may have a beneficial effect. This one particular spore-forming probiotics, and it's been several years, but definitely showed some benefit from the spores in respiratory infections. So let's go to a healthy gut, and what does this have to do with viral infections, and how can we actually use treating the gut, which is a paradigm of great functional medicine practitioners, in addressing inflammation that may lead to worse outcomes with viral infections. So a healthy gut is good microbial diversity, low levels of pathogens in the gut lumen, strong mucosal barrier, strong tight junctions, and low mucosal inflammation. So you can clearly see that blue there is representing the mucosal barrier. If we have a high diversity of protective strains, like certain keystone strains that I'll tell you about today, high production of short-chain fatty acid, and well-formed tight junctions, we have a much more healthy environment to prevent that lipopolysaccharide from entering into the bloodstream and causing cytokine storm, which we already talked about, how that can predispose or prime a system for inflammation related to the virus. So this shows basically a different situation where we have all kinds of pathogens in the gut lumen. We have the breakdown of the mucosal barrier, and we have weak tight tight junctions where you allow this lipopolysaccharide to leak in and stimulate the dendritic cells, the HLAs, and cause stimulation of IL-6, TNF-alpha, and IL-1 beta. Now, where have you heard those cytokines before? If you're listening at all to what's happening with coronavirus, clearly these are the exact same cytokines that are implemented in damage in the virus as well. So this is why it's common to that. So dysbiosis, low keystone strains like low Akkermansia, low Faecobacterium brzezinski, low Bifido longum, low Bifido acidentalicensis. And all of these, if they're low, it's representative of low keystone strains. Okay, let's go back. Low short-chain fatty acid production, also important. Disrupted mucosal barrier, which is our protective layer between the gut lumen and the enterocytes. Disrupted mucosal immune response, so weakened tight junctions, and the dysfunctional gut barrier. Too much LPS and other toxins then stimulate the cytokine response, creating a cytokine storm and leading to the diseases we talked about that are also high risk for coronavirus, which is heart disease, things like cancer or diabetes or any of these inflammatory conditions, obesity, etc. So just a few studies linked to disruption of gut microbiota, linked to obesity, inflammatory bowel disease, diabetes, etc. So dysbiosis clearly linked to these diseases. Low diversity, so lack of keystone strains, is linked to dysbiosis in inflammatory bowel disease, reduction of bacterial diversity, decrease in Firmicutes, and increase in proteobacteria. And a number of trials show that therapies correcting the dysbiosis, including fecal microbiota transplantation and probiotics, are promising. Akkermansia municiphilia. This one, if you look at a stool test, you can often see it's not there at all. And this is inversely related to diabetes, obesity, cardiometabolic disease, and low-grade inflammation. And it is a keystone strain, which means that if it's present, you're more likely to have diversity in general. If it's not present, it's a much more correlated with low diversity. So even just knowing the status of this one keystone strain, you can often predict diversity versus no diversity. So it's very, very predictive of cardiometabolic types of diseases. Another one, keystone Faecobacterium brzezinski, decreased in IBD patients, and it has a protective benefit when it is present. These are also, keystone strains often have to do with increasing mucosal barrier protection, which is why we're seeing associations with inflammatory bowel disease as well. And the epithelial barrier is a key component as well, because if there's epithelial barrier dysfunction, there's more likely permeability, involvement in creation of inflammatory bowel disease, autoimmunity, systemic infection. So as you can already see, these things are layered together because we just talked about how viral infections, and specifically likely coronavirus, will be associated with increased rates of post-infectious autoimmunity, post-infectious neuroinflammation, post-infectious, et cetera, these inflammatory conditions that are associated. And in this one in particular, you can see it triggers systemic autoimmune disease such as lupus. So this study talks about mucosal dysfunction. So when there's intestinal barrier dysfunction, there's increase in this translocation of LPS. And again, this is the priming factor that creates a milieu, a terrain that is more hospitable for viruses and other infections to do their cytokine business and create reactive oxygen species and damage, and a worse infection in the patient, for worse outcomes. This showed mucosal immune dysfunction, chronic mucosal inflammation characterized by release of IL-8 can cause destruction of the epithelial barrier. Early HIV infection. So as we know, there's some relation to HIV and the coronavirus, consistently associated with rapid, dramatic, and largely irreversible depletion of mucosal CD4 cells, T cells, and creating severe mucosal immune dysfunction and progression. So in this study, mucosal dysfunction was associated with worse outcomes in HIV. Again, a potential prototype that is related in how it acts on the immune system to other viruses. And this study talked about diversity and aging, and there was an inverse proportion. Basically, the more diverse the gut was, the less aging or better longevity that the patient had. So back to this slide, we're just going to review again before we dive into the evidence and some of the solutions. We need a healthy diversity on the left side, low levels of pathogens, strong mucosal barriers, strong tight junctions, and low mucosal inflammation. On the right here, we have low mucosal diversity, overabundance to mucus degradation, and toxin-producing pathogens, weak tight junctions, inflamed cells, leading to crossover of this LPS, triggering HLA dendritic cells, causing release of IL-6, TNF-alpha, and IL-1 beta, and creating cytokine inflammation, reactive oxygen stress, and priming the system for worse outcomes with viral infections. So clinical manifestations of LPS-induced chronic immune activation include things like heart disease, lipid problems, hypertension, type 2 diabetes, dementia, cancer, polycystic ovarian syndrome, and non-alcoholic fatty liver disease. And metabolic endotoxemia clearly initiates insulin resistance and obesity. We see this over and over in the literature. We can pretty much assume a patient with new onset diabetes, obesity, or insulin resistance is dealing with some metabolic endotoxemia and a leaky gut. This is part of the reason why in mold-related illness, which creates massive intestinal permeability by lowering MSH and decreasing tight junction function, is highly associated with development of diabetes and metabolic syndrome. We see this all the time. I just was talking to a friend today whose husband has had a mold exposure and doesn't have a whole lot of other risk factors, but is developing a pre-diabetic situation just because of the mold exposure. So this talks about the low-grade inflammation increase in central insulin resistance, irrespective of body weight changes. So this inflammatory LPS compound can create insulin resistance even in healthy weight individuals. And our results suggest that high postprandial endotoxemia precedes the development of type 2 diabetes, also shows the potential use of LPS plasma levels as a biomarker to predict diabetes. So these are so closely linked that we might even be able to look at LPS serum levels postprandially to predict diabetic outcomes. And then microbiome-derived LPS enriched in perinuclear region of Alzheimer's. So again, the gut and the brain and the viral load, these things are all connected. It makes perfect sense that our highest risk patients for severe outcomes with coronavirus are those that are also highest risk for metabolic endotoxemia. They're one and the same as far as the cytokine responses that they induce. That was particularly about lung inflammation and how LPS-induced endotoxemia is a model for lung exacerbations as well. Now, what I've seen in patients who have immune deficiencies and issues and say they're getting IVIG as treatment, they often have either gut barrier dysfunction or lung dysfunction. And if you treat those low-grade infections, inflammation, barrier permeability in the lung and the gut, they can have better outcomes with IVIG and immune treatments. This just again talks about lipopolysaccharide-induced endotoxemia in mice and lung injury. So not only gut damage and metabolic disease and prediabetes and heart disease, but lung injury. And the second one talks about chronic inflammation and persistent pathology with long-term intrathecal lipopolysaccharide exposure. So they gave mice infusions of lipopolysaccharide and they showed chronic lung inflammation. Once again, I think there's a link here to mold because mold creates massive permeability both in the alveoli of the lung and in the gut lumen. And we see lipopolysaccharides inducing chronic inflammatory lung disease and also gut disorders when there's a mold exposure as well. So what's the mechanism? These are all the different things that we see with correlation to lipopolysaccharide in the literature. So leptin resistance, chronic constipation, mood and appetite disorders. These are all linked to the mechanism of LPS entering and causing inflammation. Chronic constipation affects the enteric nervous system. Mood and appetite disorders it disrupts ghrelin and has a direct impact on appetite and mood. Depression can migrate to the blood-brain barrier and cause inflammation, along with inhibited dopamine receptors. Cognitive decline, again, inflammation in the blood-brain barrier. Loss of memory and recall, amygdala, hippocampal damage. Depression causes turnover of serotonin in the synapse and CNS, reducing the concentration in those regions. Even eating disorders, anxiety disorders, chronic pain, Parkinson's, even low testosterone in men has been linked to circulating lipopolysaccharides. And autoimmunity, as we've well established the link between autoimmunity and LPS as a trigger. So chronic activation of the innate immune system in various tissues leads to the bystander effect, where self-tissues inadvertently become targeted by the immune system, leading to autoimmunity. We've seen this before, so I won't review it again, but basically we have the good things on the left that are protective, and this problem when there's excess lipopolysaccharide, low mucus production, degraded barrier, intestinal inflammation, leaky gut, leading to cytokine response. So all of these things, low ketones, dysbiosis, low diversity, low short-chain fatty acid, disrupted mucosal barrier, disrupted immune function, and too much LPS creates the perfect storm for all of these diseases and primes the system for worse outcomes with the virus. So what is the solution? Well, one of the things I want to tell you today, I always love talking about Megaspore because I really feel like they've got such a great program that addresses this massive issue that affects all of our patients. So the first step of that total gut restoration is Megaspore. Megaspore is a spore probiotic. It has great evidence for increasing keystone strains. No other probiotic on the market has those claims because there's no evidence that things like lactobacillus actually do that. Reinforcing would be giving your specific precision prebiotic to establish the new microbiome, higher level of stable populations, and increasing those postbiotic short-chain fatty acids. And then finally, rebuilding the intestinal mucosa can be done with bovine immune globulins, selective amino acids, and polypeptides. So recondition, reinforce, and rebuild is the program. So this particular study talked about reconditioning, so Megaspore plus Mega Prebiotic, and showed that this combination of symbiotic caused increase in Bifidobacter, increase in Lactobacillus, and increase in the keystone strain Faecalibacterium prausnitzkii in the compared to the control. This is short-chain fatty acid production, 80 to 140% increase with the prebiotic, the precision prebiotic, and which is Mega Prebiotic, and then also the Megaspore probiotic together as a symbiotic. And you can see the green was increases in keystone strains. It's a little hard to read this. This is a standard way of doing the research, but clearly after treatment, donor 1, 2, and 3 all had increases in keystone strains. So bovine immune globulins, I love bovine immune globulins. There's evidence that they will passively bind H. pylori, different other bacteria in the gut, and even viruses. This is one of the things we know. We have ACE2 receptors in the gut, and we've seen some patients affected by coronavirus that have only gut symptoms. In my clinical experience, when I give them Megaspore and Megamucosa or bovine immune globulins, they do exceedingly well, and it doesn't surprise me because this passively has been shown to bind viruses in vitro. So SBI serum-derived bovine immune globulins can increase intestinal mucosal CD4 lymphocytes, improving duodenal function, promotes intestinal repair with enteropathy from HIV virus. It heals gastric mucosa in pediatric ulcerative colitis cases and decreases the pediatric index of activity in ulcerative colitis. It can bind and neutralize several toxins from C. diff colitis, and some of the other evidence I've presented in the past shows that it binds and inactivates things like viruses, streptococcus, etc. Polyphenols, so these guys are great as well, and they're in the Megamucosal product by Megaspore. These can reduce intestinal inflammation by inhibiting the NF-kappa beta cascade and block that JNK stress activation pathway, which leads to insulin resistance and diabetes. And they protect against experimental colitis in mice models. Citrus polyphenols increase butyrate production by 21% and reduce fecal calprotectin, which is an inflammatory stool marker that we use to track inflammatory bowel disease and other inflammatory states in the gut. And these mucin building blocks are also contained in the rebuild phase with the megamucosa. L-threonine, L-serine, L-proline, and L-cysteine increased colonic mucin synthesis by 95%. So in this rebuild phase, we have the bovine immune globulins, which are passively binding. We have the polyphenols, which we just talked about. And then we have these mucin building blocks, which increase synthesis of mucin and aid in short-chain fatty acid production as well. So just to summarize the total gut restoration, we have the mega mucosa for reconditioning the gut, only probiotic so far proven to increase keystone strains and diversity. Mega prebiotic reinforces the beneficial changes by increasing short-chain fatty acid production, and in conjunction with the megaspore increases keystone strains, according to the research I showed you, and then rebuilding intestinal mucosa with bovine immune globulins, polyphenols, and amino acids. So thank you so much for listening to me today. I hope you have a great, enjoyable conference. And if you are not following my newsletter, I would love to invite you. It's all free. I send it out once a month. This is just professionals. So this is only to medical professionals who are interested in integrative and functional medicine. You can pull out your phone right now and just text Healthy Me, all lowercase is fine, caps lowercase doesn't matter, to 66866, and you'll be immediately signed up. I don't share your information with anybody. This is all free, non-promotional, but I do share some of the latest and greatest stuff that I'm reading with you, and I would love for you to join me on that newsletter. So thank you so much for your time. I will go ahead and stop and take some questions now, and I look forward to seeing you all soon in person at one of the upcoming events.